Good morning, everyone. It's my absolute pleasure to be interviewing and meeting with the ORBITA-CTO investigators, Dr. Khan and Dr. Davies. Let me please start by congratulating you on this amazing trial. I myself am interested in interventional, one of the first-year cardiology fellow at Mayo Clinic, and I was waiting for the results, and I was very happy to be assigned to be meeting with you this morning. So the first question that I'd like to ask you about is to tell us a little bit about the trial and what made you think about this trial in specific.
So thank you for the question. CTO angioplasty is a demanding treatment. It's not easy to get these chronic total occluded arteries open. So the success rates are traditionally lower than standard PCI, and the complication risk is higher. The CTO PCI is done predominantly to relieve anginal symptoms, but the data that is currently available is somewhat contradictory. Some trials showing a benefit, other trials showing no benefit. And all of the trials thus far have been unblinded and open label. So really that was the driver behind designing the ORBITA-CTO trial. We wanted to simply answer one question, and that was, does CTO angioplasty truly relieve angina up and above the placebo effect?
No, that's amazing. And as we were chatting probably before the interview started, we were talking about the absence of evidence or prospective evidence to support whether CTO intervention is going to be helpful from symptom standpoint. Now, what's the main results that the CTO ORBITA trial has found?
Well, as you know, ORBITA-CTO was a randomized placebo-controlled trial, the first of its kind, evaluating whether CTO-PCI improves angina beyond placebo. The results that we found was that using the angina symptom score, the patients in the CTO-PCI arm had a significant reduction in angina frequency compared to the patients who were in the placebo arm. So therefore, overall, the angina symptom score was lower in the CTO-PCI group compared to placebo, and this was driven by reduction in angina frequency and not about anti-anginal use within the follow-up period. Furthermore, what we found out was in terms of secondary endpoints that physician-assessed CCS class was significantly improved in the CTO-PCI arm compared to the placebo group. So overall, what we have shown is that in ORBITA-CTO, the first randomized placebo-controlled trial of its kind, there has been an improvement in angina symptom score, in angina frequency, but also physician-assessed CCS class. And therefore, this is consistent across multiple endpoints. And the improvement that we saw was immediate and sustained throughout the whole 24 weeks.
And that brings me to the other point. It was a double-blinded RCT trial, but it was also a sham RCT, if I'm not mistaken. So basically with that, have you noticed or observed any safety data points that were different between the two groups?
First of all, I would like to say that we like to call it placebo, not sham. But in terms of, yes, it's the first randomized double-blind placebo-controlled trial. Now, what we did, and the angina symptom score has override events. And that means that if patients suffer unblinding because of severe chest pain or angina, if they have acute coronary syndromes or if they have death, then they score maximally, and that is included in the primary endpoint. Now, what we noticed was in both arms, there was no death, there were no acute coronary syndromes, and there was one patient who had a complication during the CTO-PCI procedure, which meant that they had to be unblinded, and that scored at a high rate. Otherwise, there was no real safety concern from our perspective, and what the patients did have in terms of events was expected, which was angina episodes, and they were requesting anti-angina medications throughout the follow-up period.
And this makes sense. And one of the clarification questions I have between nomenclature, placebo versus sham, because I've seen it a couple of times reported, at least on X, between this or that. So what's your thought about this?
I think, look, I'll actually pass over to John.
I mean, we are passionate about this. I mean, to my mind, the word sham has various connotations. And to us British people, if something's a sham, it's an abomination. It's horrible. It's something that's gone badly wrong. Yeah. And so we tend to avoid the word, therefore, sham, because of those connotations. And when you're doing drug trials, we're very used to a placebo-controlled trial. and we call it a placebo-controlled trial. If I'm doing a trial of bisoprolol, I don't call it a sham-controlled trial of bisoprolol. I call it a placebo-controlled trial. So, you know, to all intents and purposes, what we have done here, because we have managed to successfully blind these patients to their treatment allocation, it means that, you know, and one set of the patients has undergone an identical procedure, except for the fact that they haven't had a coronary angioplasty. Then that really is defined as placebo. Yeah, so I hope that answers your question.
That's very helpful, and even for me on a personal level, just for my own education. The other question I have when it comes to the anti-anginal therapy for those patients, part of the selection criteria, how was it like when it comes to what medications, classes of medications, and rough estimation of frequency of patients' anti-anginal therapy?
That's an important question, and I think it's very important that you understand that these patients, when they were enrolled, were symptomatic on at least a minimum of 3 standardized units of anti-anginals. Now, you can look at our paper and you can see previous papers as well, what each standardized unit refers to. For example, bisoprolol 5 milligrams would be equivalent to 1 unit of standardized anti-angina. So these patients had to be symptomatic on anti-anginals, and that's when they would enter the study and remain in the study, even if they were optimized. So if they became asymptomatic pre-randomization, they would exit the study and they wouldn't continue. So what's important is in both in the PCI and placebo arm, there was a significant symptomatic burden. All right, so that's first step. And then patients got randomized and we stopped the anti-anginals. And this was important to see the true effect of CTO PCI in the follow-up period. Now, if patients had symptoms, then they called the blinded research team and requested anti-anginals. The method that we reintroduced anti-anginals was pre-specified, okay, so that all patients in both arms got the same stepwise up titration that was tailored to each patient. For example, if they had an allergy and they could not have, or had an intolerance, then obviously that wouldn't be given to them, but an alternative would be. And this was right across all 50 patients in both arms, that there was a standardized stepwise approach and reintroduction that was already established at enrollment.
And that's extremely important to understand, since the therapy really targets angina. So if we have a confounding of anti-anginal therapy, or at least at baseline, but based on what you just shared with me, doesn't look like there was. And then there was a stop or hold of medications before treatment intervention started.
At the moment, this is the first placebo-controlled trial. We use anti-anginals, but we don't actually understand fully what the impact of these anti-anginals are. And I think, John, I think you would like to say a word here about in terms of anti-anginals and what evidence there is, especially just in general for angina, but also in CTOs.
Well, yeah, I mean, there's very little evidence in CTO angioplasty per se for anti-anginal medications. One has to look hard into the published literature to find good double-blinded controlled trials of anti-anginal therapy in chronic total occlusion patients. So we probably don't know what the effect is, quite simply. And I think, that's certainly an area where future studies should concentrate on. What we know from the studies thus far of angioplasty, and including obviously our study, the ORBITA-CTO study, is that that PCI is a good treatment for angina in these patients. What we don't know is it a better treatment than tablet therapy? And that may well be some future thoughts for studies that are up and coming.
And my last question is, what was roughly the rate of angioplasty for CTOs at your institution before ORBITA-CTO? And how do you foresee that this would be at your institution? And probably now we start to think about worldwide, including here in the US, based on these results.
This is really important. It's important that physicians and certainly interventional cardiologists read the inclusion and the exclusion criteria very carefully and have a look at the consort diagram to see what patients were included and which patients were excluded. We're very proud of the fact that the patients were selected from a consecutive group of over 400 patients that were referred to our regional chronic total occlusion angioplasty service. So there were no patients that were excluded from the screening process, and that's really important. We did not cherry pick which patients we wanted to include and which ones we didn't want to include. We took consecutive patients, screened them, and those patients that were eligible for the study were offered the study. And really the only reason why eligible patients did not end up in the study was because the patients themselves did not want to be randomized, and that's fair enough. What we were very careful not to do was to allow any bias from the heart team to say we don't want that patient included in the study because we just want them treated. That was really important. We did not do that because that would have really compromised the study results. So have a look at the inclusion criteria. You know, I think top line would be heart team as symptomatic patients who have got angina, number one. Number two, heart team discussion with a CTO operator to make sure that the angioplasty is feasible and likely to be successful without complication. Number three, this is a study of JCTO complexity 3 and less. So this doesn't include the really difficult ones where the complication rate will be higher, even in expert hands, and the procedural success will be lower.
Makes sense. Once again, congratulations on the ORBITA-CTO trial, and thank you so much for taking the time to meet with us this morning.
Thank you very much. It's been a pleasure.
Thank you very much, and good luck with both your careers.
Thank you.